Just to, I'll take us through glaucoma capacity assessment in Kenya, but just to introduce myself, I work with CBM Global Disability Inclusion. Many of you have known CBM for a long time, but CBM split into two. We have CBM International and CBM Global Disability Inclusion. So I work as an inclusive eye health advisor with CBM Global Disability Inclusion. Today I'll be presenting about glaucoma capacity assessment in Kenya, a survey which was done last year in 2021, just to help understand the capacity of the country to manage glaucoma or to offer glaucoma services, and to help make recommendations that can improve the services, since glaucoma has not gotten a lot of focus. A lot of focus has gone into cataracts and all that. So the Ministry of Health through also thought it's wise to understand really the gaps around glaucoma. So the outline of my presentation. Confirm if my slides are moving, please.
Yes, they are seen, Dr.
Okay, it's on slideshow?
Yeah, it's not yet on, yeah, now it's on slideshow.
Okay, thank you. So that's the outline of the presentation. We'll go through the rationale, why the capacity assessment was done, briefly on the methodology, the findings, recommendations, and acknowledgements. So the prevalence of glaucoma is 4.3 among persons aged 50 years and above. This is based on a RAB that was done in Nakuru, but it is not very recent data. Probably another survey was done, the prevalence will be different, I don't know, but that's from what I could get for persons above the age of 50. I won't go into detail about this because I'm sure this has been discussed many times before. But just to explain what the Ministry of Health has done in terms of glaucoma, in 2020, the glaucoma guidelines were developed and dissemination has been ongoing. I'm sure some of you have seen the guideline, though from the survey we realized that some people have not received the guideline. So to help have a successful implementation of the guideline, the ministry thought it's important to do a glaucoma capacity assessment to understand the situation in the country so that we know which areas to intervene in or what areas to prioritize. So yeah. So briefly on the methodology, this was an online survey led by Ophthalmic Services Unit with the support of CBM Global. And the target population was all the clinicians and ophthalmologists seeing glaucoma patients. So the target population was 344 OCOs and ophthalmologists combined. The survey was conducted between September 2021 and February 2020, but the data collection was in November 2021. I'm sure some of you can remember Dr. Gishangi circulated a survey for people to fill out. So from our findings, we got 32 participants from 19 counties. Out of these, 25% of the respondents were from Nairobi County and 2 were from Mombasa County, but they were from different hospitals. Then where we got more than one response from one hospital, we marked the responses to avoid duplication. So we got a response, after doing all that, we got a response rate of 9.3%. So the distribution of the participants, we got a very good representation of the different regions. So we classified, sorry? Okay, so we divided the participants according to the economic blocks. So we had the Lake Region economic block and we had participants from the 4 counties you can see on the screen, Migori, Bomet, Kericho, Vihiga, and Busia. We also had the North Rift economic block where we had Uasin Gishu and Samburu. The Central Kenya economic block, we had Nakuru, Tharaka Nithi, Murang'a, and Meru. Then in Pwani, we had Mombasa from 2 different hospitals in Mombasa, that is. Then Southeastern Kenya economic block, we had Makueni. Then the Frontier Counties Development Council, we had Wajir and Mandera. Then we had Narok for Narok Kajiado economic block and 8 respondents from Nairobi, but from different facilities. So one of the questions we were asking the respondents was the eye care workers that they have in their eye units. And these were the responses that we got. 61 of the respondents responded that they had an ophthalmologist in their eye unit. 79% said that they had an OCO, a general OCO, and 28% had cataract surgeons. 82% had at least an ophthalmic nurse. Optometrists were were reported in 36% of the responses, and others were 14%, and these included low vision therapists, ophthalmic assistants, and a health records officer. So at least in all the facilities, there was at least an eye care worker. There was at least an ophthalmic nurse with an OCO, or a combination of an ophthalmologist with the OCO and the ophthalmic nurses. So at least there was a clinician or an ophthalmologist in every hospital. Then we asked for the services that they give for glaucoma, the top 6 services that are offered in the different eye units for glaucoma. And all the facilities at least could screen and diagnose glaucoma, and 79% could offer medical treatment. However, only 39% could do trabeculectomy, and only 14% could do SLT. And cryotherapy and cyclophotocoagulation was reported in 4 facilities. Then glaucoma drainage devices was reported in 7, and rehabilitation 4. So we also tabulated the number of cataract surgeries and compared with the national findings. And it was quite, would I say, shocking that the reporting on the national, or on the DHIS2 platform is quite low, because from the survey we got, so we did the survey for we checked data for 2019 and 2020. The survey happened in 2021, so we didn't have complete data for 2021, so we didn't use that data for 2021. Then we all know COVID started in 2020, so we thought that we might not get adequate data from 2020. So we did the 2 years, 2019 and 2020. So the number of surgeries, glaucoma surgeries done in 2019 in all the facilities, from the response we got from all the respondents was 1,078 and 971 for 2020. However, you can see what was reported on the DHIS, 322 and 168. So yeah, we need to improve on our reporting on the national platform. Then we compared, we looked at the number of surgeries being done in the different eye units. And if you look at the table on the second column where you talk about the eye units doing 0 surgeries, we had 16 out of the 28 units reporting that they don't do any TET or any glaucoma surgery. Then we had 25 to 50 surgeries per year being done in 6 units. Then 2 units were doing between, sorry, the first one is supposed to be 1 to 25, sorry, that's a typing error. Then the second one is 25 to 50. We had 2 units. Then we had 4 units doing high volumes over 100. And all of these 4 units were in Nairobi. So some of the counties that reported that they don't do cataract surgeries included, sorry, not cataract surgeries, but trabeculectomy, included Meru, Wajir, Vihiga, Migori, and Vihiga, just to clarify, we didn't get a respondent from Sabatia. So by Vihiga, we mean the Vihiga County Hospital. Then Migori, Makueni, Mombasa, that's the county hospital also. Then Nyandarua, Samburu, Nakuru, Uasin Gishu County Hospital, then Narok, Kericho, and Mandera. Then we went further to ask more details about the surgeries on availability of mitomycin C or 5-FU, on SLT and the glaucoma drainage devices. So of all the 14 facilities that were doing glaucoma surgeries or trabeculectomy, only 9 of them had access to mitomycin C. And we looked at these 9 facilities and looked at the number of surgeries that they had done using mitomycin C, and we got 77%. 77% of the surgeries in these 9 facilities had been done, and mitomycin C had been used for 2019 and 86% in 2020. Meaning, but that for some facilities, the supply is still not consistent. There are periods or there are times when they don't have access to the mitomycin C or 5-FU. Then on SLT or selective laser trabeculoplasty, 5 facilities, all of them in Nairobi, indicated that they had an SLT machine. But when we looked at the data, only 2 facilities reported that they had done SLTs in 2020 and 2019, and they were between 25 and 37 total for the 2 years. Then for the glaucoma drainage devices implant, 5 facilities reported that they do offer this service, and the total number of surgeries for 2019 was 328, and 670 in 2020. So the number is quite high, means this is being done more and more, and it's increasing by the years. Then we looked at the availability of anti-glaucoma medication. 3 of the facilities said that they didn't have any anti-glaucoma medication, and I'll still go into that into more detail. Then 8 facilities reported that they only had timolol, and 7 facilities reported that they had timolol and 1 other anti-glaucoma eye drop. Some had timolol and Diamox, some had timolol and pilocarpine, a combination of 2. Then those facilities that had more than 2 anti-glaucoma medication, including the prostaglandin analogs or the combinations, had we had 10 of them reported that they had that in their hospital. So looking at the facilities that said they didn't have any anti-glaucoma medication in the hospital, so KNH was reported, and we followed up this with a phone call, and I was told that it's occasionally available. It's available sometimes, not available throughout. Was Ngishu County Referral Hospital was the other one, and Makueni. And the reason why I've pointed this out is because all these hospitals have an HIF cover, so it's an area, an opportunity for advocacy so that these anti-glaucoma medications can be availed in the hospital. Then we also looked at the equipment available in the different units represented by the participants who participated in the survey, and all the participants had a functional slit lamp in their eye unit, which was good. And 9 said that they didn't have a Goldman tonometer, and we all know it's very important in terms of diagnosing and managing glaucoma. 26% reported that they had a gonio lens, 8 facilities. Then 10 had a visual field machine, and some county hospital, actually, like Kericho, Bomet, Murang'a, Mombasa, Nakuru, and Nairobi. And Nairobi, by Nairobi, I mean there was KNH and some other facilities. They reported that they had a visual field machine, which was quite impressive. And we'll talk a little bit about that later. On eye health financing, or NHIF coverage, basically, 24 of the respondents indicated that NHIF was available in their facility, and 14 indicated that NHIF covers for all ophthalmic medicines. Sorry, I got muted, sorry. So as I was saying, 24 of the respondents indicated that NHIF covers for eye health services in their hospitals or in their units. And out of these, the 14 indicated that it covers for all ophthalmic medicines. Then 16 indicated that it covers for surgeries. Then 9 indicated that it covers for both medicines and for surgeries. Sorry, then on referral, information around referral for glaucoma services. So 21 of the respondents reported that they had referred, that they had needed to refer patients for management of glaucoma. And the remaining 7 participants were from tertiary hospitals and therefore did not need to refer. Then a total of 379 patients were referred for further management of glaucoma from what was reported. And the number of referrals ranged from 1 patient to 100 patients being reported in one hospital. Then some of the reasons they gave for referral, number 1 was lack of visual fields or equipment for investigation for glaucoma. The other one was for specialist review. Also lack of eye drops was reported in one hospital as a reason for referral. Then glaucoma drainage device surgery was also another reason. And for those hospitals that were not offering any glaucoma surgery, also referred for surgery. Then we had others, including things like patient preference, distance from the hospital and such, which were also reported. So that some of the centers that they reported for referral included Kenyatta National Hospital. Okay, they are listed there. Kikuyu Eye Unit, some level 5 hospitals like Machakos and Embu, Kisii Eye, City Eye, Sheila Eye, Sabatia, Tenwek, Nakuru, and Lions and MTRH. So basically, those were the findings from the survey. So I'll just go through the recommendations from the survey. And I hope that even when we are during the discussion of the plenary, we can also be able to add onto this so that we can strengthen glaucoma services in the country. So one of the recommendations was that we need to capacity build the county ophthalmologists to offer glaucoma services. As we saw, only 14 of the respondents were able to offer glaucoma surgeries and all that. So probably we need to do some refresher training or to find out why they are not doing these surgeries. If it's a skills gap, then do some refresher training, identify training centers and potential trainees and trainers. Then the other thing, and we saw one of the leading causes of referral was lack of visual fields and equipment for investigating glaucoma. So we need to equip the counties so that we don't have unnecessary referral. We need to have at least the county hospitals should at least have a visual field machine, have some basic package for glaucoma management, like a visual field machine and the eye drops and all that, so that they don't have to refer every other patient. Then we need to do a lot of advocacy on glaucoma. And by advocacy, we need to target various levels. At the county level, we need to advocate for the counties to stock anti-glaucoma medicines as per the essentials medicine list. Now that we have a fairly comprehensive essential medicines list with anti-glaucoma eye drops, so we need to advocate for inclusion of that, and even with NHIF. We also need to work with our NGOs when they are designing their projects, not to only design cataract projects, but also include some element of glaucoma as well. When they are buying equipment for cataract, they can include 1 or 2 equipment for glaucoma as well, because as you all know, glaucoma is one of the causes of poor outcome for cataract patients. So still, so if we're able to investigate and manage, then it also impacts positively the cataract outcomes for those who have cataracts. Even for pharmaceutical companies also, it's one area that we can advocate. They can, apart from supplying the eye drops and apart from the eye drops that they supply, they can also try and help create demand for these eye drops, but by helping, by supporting the screening programs and such. Then one of the things that we discussed with Dr. Gishangi's office was that this annual glaucoma capacity assessment needs to be done annually so that we can analyze our progress and see how we are progressing, whether we are improving, and also to help us identify the achievable interventions each year so that we can intervene in those areas and so that we can move glaucoma management, we can improve glaucoma management in the country. We also need to strengthen data collection so that we can have an accurate picture of glaucoma in the country. You saw the DHIS data that I shared. There's a lot of underreporting, so if we can all report, then we can have a clearer picture and it's easier to advocate for improvement and all that. Then task shifting, that is up for discussion, especially for those counties that don't have an ophthalmologist but have a cataract surgeon. Is it something that we can adopt, or is it something that we can think about it? Then the other thing is what are the sustainable innovations that can be adopted around glaucoma? Yeah, so, and my last slide, I just want to acknowledge the people who supported this survey from the CBM Global team. We have my director, Dr. Dani Haddad, and Debbie for developing the survey and for the support she's given. Then Dr. Gishangi's office and all the participants who participated in the survey, and even for listening in today. Thank you.
Thank you very much, Dr. Bitok. So thank you again, Dr. Bitok, for that wonderful presentation. So today was more of a tag team, so we'll have another presentation before we start on the questions and answer. So our next presenter, she's one who does not need a lot of introduction, is Dr. Sheila Mako. Dr. Sheila Mako has taught most of us the glaucoma that we are practicing in the country. We have learned from Dr. Mako. So she's a consultant ophthalmologist. She's also a glaucoma specialist with, she practices in Iridian Eye Center. She's a senior lecturer at the University of Nairobi. She's a lecturer also part-time at Aga Khan University Hospital. So Dr. Marco, learned to welcome you. You start your presentation. So after your presentation is when we will start the question. Again, to remind, you are welcome to post your questions, comments, encouragements, and everything, even acknowledgements in the notice board. Thank you very much. Welcome, Dr. Marco.
Thanks, Dr. Frank. It's a pleasure to talk to the group again. And I just wanted to put this slide up because this is a World Glaucoma Week. We're celebrating it from Sunday to, basically Sunday to Sunday. And the theme is, the world is bright, save your sight. So we used to do a lot of glaucoma screening countrywide a few years, before COVID. And hopefully once COVID is actually over, we'll probably go back to screening because we used to reach out to a lot of people and involve a lot of institutions, and it was a very successful program. Maybe next year we'll start the program again. Okay, so as Dr. Frank has said, he's from Nyamira, so it's interesting that he's moderating this talk. And I'll just talk a little bit about screening, then go into the study that we did. So glaucoma screening is a bit of a challenge because Africa has a high prevalence of glaucoma. The commonest type we know is primary open angle. And this glaucoma is progressive, irreversible, and basically, like Dr. Bitok has said, it should warrant some prioritization in terms of screening and also improvement of case finding strategies. Because we know this disease is silent, so we should find ways and means of trying to screen and catch it early and treat early. Just a little bit of some information from studies that have been done. More than 50% of glaucoma patients are undiagnosed. And also 50% of patients who are on treatment for glaucoma do not actually have the disease. So a lot of patients are getting eye drops and surgeries and maybe they don't have the disease. About 50% of glaucoma patients, they don't use their eye drops regularly. You've seen patients who come and they have not used their drops for months or weeks. And also 50% of newly diagnosed patients have previously been seen by an ophthalmologist or an optometrist or an OCO, but their condition was not diagnosed. So these are very interesting statistics. And when it comes to glaucoma per se, it's very difficult to do the population-based screening where you go into a population and screen everyone for glaucoma because it's expensive, we don't have the equipment, we don't have the manpower. But what we advocate for is what is called case finding, where we screen a smaller group of people based on the presence of risk factors. For example, screening a glaucoma patient's family for glaucoma. So if a patient comes to see you and you diagnose the disease, you screen their family, immediate family members, or even screening all diabetics because diabetic is one of the risk factors for developing glaucoma. And case finding basically involves actively searching systematically for people at risk rather than waiting for them to present with symptoms or signs of active disease. So a little bit more into case finding in glaucoma, to make it more practical, we actually talk about opportunistic glaucoma screening. So what does this mean now in our different areas of practice? So for patients who visit ophthalmologists or any other eye care workers, including ophthalmic clinical officers, OCOs, optometrists, they should undergo a fairly comprehensive clinical exam. This means any patient who's over 35. So in Africa, we've reduced the age from 40 to 35 because we catch a lot of younger people with glaucoma. Anyone who visits an ophthalmologist can be considered potentially a glaucoma suspect and should undergo an eye exam, which we do regularly, but sometimes we miss out on some things. Of course, you do the visual acuity, extraocular motility, pupillary reaction, slit lamp exam, where you examine the anterior segment, take the intraocular pressures, through whichever method you have available. Assessment of the anterior segment, I've said that, and a quick fundus exam. And you find that this assessment, if somebody walks into your clinic, it can take less than, in under 4 minutes, you're done. And especially looking at the optic disc and a quick way, if you have a quick way of taking intraocular pressures, for example, using a tonopen or an eye care tonometer for in all the patients who walk in, you can be able to pick out patients who may have had, who have glaucoma and send them for further test. So any person who's found to have elevated pressures of more than 22 or have a suspicious disc, that's increased cup to disc ratio of more than 6, should undergo further tests, for example, visual fields, OCT, CCT, etc. Now, the AAO also recommends this kind of opportunistic screening, where they say people who are at risk of developing glaucoma should have a complete eye exam. This is just a guideline, not really strict, but if you're between 40 to 54, one exam every 3 years, and a bit more frequent when you get older, 55 to 64 every 2 years, and above 65, at least you should have an exam every 6 to 12 months. And the risk factors they have given are if you're above 40, if you have a family history, if you have high pressures, if you're an African American, if you're an Asian, or high myopia, high hyperopia, or if you've had previously an eye surgery, especially like a planar vitrectomy or an eye injury, or if you're diabetic, or if you have history of steroid use. So this is just according to the AAO guidelines. So we can apply those guidelines to our settings. So anyone who walks in, consider them a suspect. So let's go down to the screening that took place in Nyamira. So this was a study that we conducted, and I'll come to the exact timelines, but it was published last year at the Journal of Glaucoma in March 2021. And those are all the study, all the investigators. You can see Prof. Kiage is there, as well as Prof. Damji. Most of you are familiar with those. Now, as an introduction to the study, most specialists tend to be concentrated in urban areas, and we find that people who are found in underserved or in the rural communities are not able to reach this specialist. So some telemedicine technology was designed to target this underserviced predisposed population, so that you can do some triage and assess them and send their information. And this is specifically with a focus on glaucoma. And also we've talked in the past about diabetic retinopathy. They do a lot of teleophthalmology, and we are trying to see if glaucoma, this can apply as well. So when the information is sent to the ophthalmologist, there's a remote analysis of the patient's information, and the patients and the ophthalmologist sends a report back to the center where the patient had presented, and the patients are given their diagnosis and told their management plans according to what the ophthalmologist has reported. So the main objective actually for this study was to examine the prevalence of glaucoma and glaucoma suspects in rural residents who are otherwise unlikely to have access to care through a novel targeted teleglaucoma case finding model. And though not a primary objective, other ocular diseases were also analyzed, and patients that needed further care were referred to a nearby hospital. And the program or the software that we used is called the Secure Diagnostic Imaging. You can look it up on the internet, and it's a system whereby we are able to gather information from the rural facility and send it to a cloud system, which is accessed now from the our main hospital, and we'll look at how it was done. So we identified Nyamira, and this is because it was quite densely, it's quite a densely populated area and underserved, and it's quite rural. And another benefit, another advantage of Nyamira is that it was 30 kilometers away from the referral center, which at that time was Innovation Eye Center. I think it's called Kisii Eye Hospital now, I'm not sure. So at that time it was called Innovation Eye Center under Prof. Kiage. So the reason why we located Nyamira was its proximity to Kisii, as well as the high population density and the ruralness of the county. And we sent a team to do a recce. You can see there's Prof. Kiage at the back there, and Prof. Damji at the front, and some colleagues from Canada, as well as the other nurses and OCOs that we found there. This was our team. So for the methods, it was a prospective cohort study. We did a case, we used the case finding model, and I'll go more into that. It was approved by the Aga Khan Ethics Board, as well as the ethics board from the University of Alberta. And we conducted the study between March 2014 and April 2015. Who were referred from many of the following places. Initially we targeted the hypertension or diabetic clinics and diabetic clinics within Nyamira District Hospital. That is what it was called then. And also nearby schools, marketplaces, through marketing campaigns, mainly in churches. And we handed out flyers, we put up posters, and also any family members of patients who came to, like the ones who were coming to visit their relatives in the hospital, we targeted those. And exclusion were anyone who was unable to tolerate the screening exam or to have their photos taken for any reason. So this is Nyamira. We went to the marketplaces, we went to the bus stops, we put up posters, we handed out flyers. Our posters and flyers were mainly in Kisii and in Kiswahili, so that the patients could be able to read and understand what we were asking them to do. We were asking them, basically, we were educating them on glaucoma and asking them to come for the eye check at the Nyamira level 4 hospital then. And this is just an example of the posters that we put up all over the county in churches, schools, marketplaces, both in Kiswahili and Kisii. So once the participants came to Nyamira, they were seen by a trained nurse or the clinical officer who was able to obtain a good, to get consent, of course, to participate in the study. Also took a good history, did the visual acuity assessment, did the intraocular pressure, we used a tono pen, and also did the central corneal thickness. After that, the patient underwent visual field testing using the frequency doubling technology. And we had to dilate the patients to get a good 3D, to get good clear 3D digital photos of their optic nerves, as well as their, the posterior retina, the posterior pole. All information was uploaded as a teleconsult to the SDI, the Secure Diagnostic Imaging website. And then grading, so I was able now to access all this information from Aga Khan Hospital, and the grading of the photos was done within 7 days. The report was sent back to the Nyamira team. And once the nurse received the report, they downloaded it and printed it. They called the patient. All patients were called back. And even if they were normal, they were reassured and told there was no disease or no problem. And if they had glaucoma or any other eye disease, including cataracts or refractive errors or Anything else that needed referral, they were referred to ophthalmologists, the ophthalmologist in Kisii, or anything that could be handled within the Nyamira Center, they took care of it. So this is just a picture of the nurse doing the frequency doubling technology visual field test. And on the right, she's taking IOPs using the toner pen. This is the clinical officer taking digital pictures of the retina, and all these were uploaded and sent. So this is just a sample of what they would send us as the form where preliminary demographic data was filled in, any medication the patient was taking, any history of eye surgery, family history of glaucoma, systemic conditions, visual acuity, tonometry, pachymetry, whether they were dilated, and whether the FDT was done, and photography. And this is on the right is a sample of the FDT test that they also uploaded. I have to comment that the FDT test had so much false positives, false negatives, so we couldn't really use the visual fields from the FDT as we couldn't use them in our analysis. There are too many errors. So I have to apologize to Prof. Kiagia, but I had to use his picture. And all the information was put in the secure diagnostic imaging system and sent to Aga Khan, whereby we used 3D, we used such glasses to see the 3D view of the optic nerve, grade it, and send a report back. So this was a sample of a patient of what a report that was sent back looked like. The visual acuity of this patient was very low. Counting fingers 1 meter, counting fingers 3 meters. Funny enough, their intraocular pressures were normal. Probably they're already on glaucoma treatment, but you can see, though there's some reflection there, the cup disc ratio, especially on the right, was quite advanced. And such a patient was sent to Prof. Kiage for urgent management. This is another picture of probably a patient who had 612 and hand movement. The pressures were borderline, but the main thing is that they had a cataract on the left eye. And also what was uploaded was the anterior segment picture. So we could be able to see the cataracts on the anterior segment pictures. Of course, if you have a hazy view on fundoscopy, such patients were sent for cataract assessment to Kisii. So the results, we screened 1,180 patients. Almost half were female, half were male, 53% versus 47%. The mean age was about 57 years. Out of all these patients, we referred 350 patients to Kisii Eye Hospital. Of those referred, only 66 actually went, because later on we did a follow-up a few months later and looked at the records from Kisii to see how many actually went to receive treatment. And unfortunately, only 19% went. And for the ones who didn't go, we actually called a few of them and asked them why not. Most commonly, they didn't have bus fare. So anyway, so this is just a distribution by age. Most patients are between 51 and 60 years, but that was how the age distribution looked like. The occupation, most of the patients were farmers, as you can see. I think Nyamira is a highly agricultural county. So farmers and teachers were the most common occupations. Then the others followed. Now, in terms of just some baseline demographics, so when we've talked about the ages and the gender and the sex, but the IOPs, for the average IOP was about 16. The ones who were diagnosed with glaucoma had slightly higher intraocular pressures of 19-20. Remember, the tonopen is not very precise, but at least it will give us some details, and it's useful for screening. Visual acuity in all cases was about on average between, this is the logma, so this is about 612 to about 618. However, in the glaucoma cases, the definite glaucoma cases, the vision was quite low. You can see this is about between 660 and probably 636. The CCTs were on average between 530 to 540. More about the results. So normal eyes, most patients who presented, most of the participants had normal eyes, about 70%, and about 8% had cataracts, mature cataracts, another 4% had early cataracts. But I just want us to focus on this part where the glaucoma suspects were 4.1%, and actual glaucoma were 3.3%. So basically the suspects are those ones who had pressures of above 21 or had a suspicious disc where they needed further follow-up for evaluation. But actual glaucoma, like the case I had shown you, those actual cases were about 3.3%. So when you add this up, you'd find that if these suspects actually turned out to be glaucoma, then the prevalence of glaucoma in this population would be about 7%. And in some African studies, the prevalence ranges between 4 to 7%. So it's more or less within the range from actual population-based studies. Also, diabetic retinopathy, we picked it up. It was about 1.7%. And optic atrophy, and most of these patients with all these other conditions were sent to KC for further management. When you look at the patients who had glaucoma, the ones who had early were quite few. Most of them had advanced disease. Probably that's why we were able to pick out the CDR of 1, because these are, it's quite obvious on the photographs, but most had either advanced disease or moderate disease. And that usually is the normal presentation in African patients, and especially in a very rural population that doesn't have access to care, they would present late. We, as I said, we referred 335 cases. Most of them were cataracts, as you can see, 149 patients, followed by the glaucoma suspects and the glaucoma patients, and all the diabetics and the retina optic atrophy. Other reasons were the corneal, either a problem with the cornea or any other, there are so many other, a few diagnoses that we made, but this, you can see how the referrals were spread out. So the limitations for this study, we had quite a high number of ungradable cases, 11%, where we were not able to take pictures due to the media opacity. So we still were able to take the pictures of the anterior segment, but we were not able to grade the glaucoma because the disc was not visualized. So maybe we were missing some cases of glaucoma. Challenges with classification of glaucoma, for example, angle closure, we didn't do any gosnioscopy. Secondary cases were not picked up easily, e.g. pseudoexfoliation. And I must say at that time when we went to Nyamira, they did not have a slit lamp. So it was very basic examination. Take your pressures, take your vision, take your pressures, do your visual field, dilate, regardless of what other problem you have in the anterior segment. The FDT test, as I said, was quite unreliable, and we could not use that to stage the glaucoma. Also, this model had a significant startup, maintenance, and administrative cost. It was very, very expensive. The machine, the equipment that we had to transport in Nyamira, it was quite expensive. The SDI software, it's very expensive. So the payment, we had to pay everyone, the nurses, the cleaners, everybody had to get paid. It was a very expensive process. And of course, we saw the challenges with patient monitoring and follow-up post-referral due to lack of transport, financial difficulties, etc. So in conclusion, The study actually demonstrated the benefit of teleglaucoma model in detecting glaucoma with a prevalence of 3.46% in a high-risk rural population. And we've seen also that if you have a collaborative team of frontline screeners and glaucoma specialists and a well-defined care pathway, it's a good method, and you can provide care for glaucoma patients through this case detection, triage, and referral. The recommendations are maybe for future studies, we could adopt newer technologies into a similar teleglaucoma model, with a focus on follow-up of the health outcomes within vulnerable populations. So in future, maybe we can go more into details on how better to do this kind of assessments and this kind of, especially the referral system. So we'll work around that, but that is in the future. So I'd like to acknowledge Prof. Damji and Prof. Kiage, of course, the University of Alberta with the support team they gave, and the Grant Challenges Canada. They were the source of funding and support for this study. So thank you. That's the end of my study. I put this slide here because I can't believe this was almost 5 years ago. You can see Zara there, Dr. Lois, Dr. Muturi, Halila, Jeff, and I can't remember the guy standing next to me, but thank you, and I'm ready to take any questions.
Thank you, Dr. Marco. I'm sorry I cannot share my face. We have a blackout here. So thank you, Dr. Marco, again for the wonderful presentation. Now we are going to plenary questions and answers and any comments. So I'll start with Wendy. Wendy N has asked, how accurate are eye care and tonopens? Then question 2 is from Dr. Amos Kibata. What did the posters say? Who was to come for screening? And the people with eye problems or of a certain age? So let me repeat it again. What did the posters say? That's the first question of Dr. Amos Kibata. The second question, who was to come for screening? The third question is, who are the people with eye problems or of a certain age? I hope I've gotten them right. So we have those two questions. Maybe either of you, Dr. Bitok, you unmute yourself, Dr. Bitok, Dr. Marco.
Okay, so I'll just start with the posters because that is easy. So we got an a translator, and anybody who was over the age of 35, anyone who was over the age of 35 was invited to come for the screening. So whether you have an eye problem or not, everyone was invited. And the posters say, I'll look at the Kiswahili ones. Basically, if you're more than 35 years, wale walio na historia ya glaucoma, if you have a family history of glaucoma, if you're African, obviously if you're reading this, you're African. Anyway, and if you have, if you've worn glasses or if you had diabetes, we try to make it as simple as possible, but I hope that answers the question. Now, in terms of accuracy of eye care or tonopens, these are very good for screening. Once, you can't, if you're in a screening program, you really cannot do a Goldman applanation tonometry on 1,000 people. So the only problem is that between eye care and tonopen, I'm more biased. I like eye care because you don't need calibration. You can reuse the tips. And between the pressures of 5 and 55, it's fairly accurate and more comparable to what you'd get with Goldman applanation tonometer. The tonopens, The older types, you had to do the calibration, and you can't really reuse the tips, and we have three tonopens in the department right now. They are dead. They're not as robust, I think, or hardy as the eye care. This is just my own experience. I'm not marketing eye care or anything, but I found, we have 2 eye cares in the department that are constantly being used by the residents, and they have lasted 5 years without a problem. So accuracy, let me just say they're very good for screening because they are the most practical thing to do. But if you're if you're in a center that where you're actually seeing glaucoma patients and following them up, you have to use the Goldman applanation tonometer.
Dr. Marco, there's another question. There's another part of Dr. Kibata that, so who are being screened, and were these people with eye problems or of a certain age?
Everybody over 35 came, whether you had an eye problem, whether anyone who was above the age of 35 was screened. So the poster was open to, the screen was open to everybody.
Thank you. So there's 3 more comments and questions here. One is from Dr. Mukaya Angela. I think she's my sister from here. The posters were top, and particularly being in Ekegusi, at that, I need to look at them keenly. Thanks, the talks were good. So this is just a comment that you managed to write it in our local language here. Number 2, there's a question from Dr. Vivian directed to Dr. Bitok. So Dr. Bitok, she's asking for the hospitals where trabeculectomy was done in the hospital. Was there an ophthalmologist or not?
Thank you. Okay, can I go ahead and answer? Sorry.
Yes. Go ahead, Doc.
Okay. Yeah. So, thank you, Dr. Vivian. So for the hospitals that were not doing trabeculectomy, some of them had an ophthalmologist, and that's why in the recommendations we recommended that it's good to find out why they're not able to do. Is it the lack of consumables? What exactly the issue is? Is it the lack of skills? Do they require refresher training and all that? So that's something that this survey will try and follow up to see what can be done to intervene in those counties here.
Okay, thank you. I hope Dr. Vivian Ongore, that is clear. She's usually called her, she's a member from Nyeri. I hope you are taking care of the retired president well. So Dr. Kipsang Manasseh, she's asking, he has a transpalpebral tonometer. How accurate is it compared to the Goldman tonometer? And also compared to tonopen and eye care? Any of you can go.
Personally, I don't have any information or experience. I don't have any experience with the transpalpebral tonometer. They say it's fairly accurate. I don't know. So one thing we can do probably is just to sorry?
No, so I think somebody has just unmuted. Just assume that one. Just continue.
Okay. Probably one thing you can do, Kipsang, is for a few patients, just take use the transpalpebral tonometer and compare with the Goldman and see. And of course, I think there are studies out there that can compare all these different methods. So I really have no experience with that at all. So I can't really comment on that, on its accuracy or on its comparability between the other tonometers.
Okay, thank you. I hope Dr. Kipsang, that is clear. So Dr. Oscar Onyango is asking, what are the indications for laser trabeculoplasty? That is from Dr. Oscar Onyango. Question 2 comes from Dr. Kibata again. Who should get trab and who do you give drops? Kibata is very active in this group. Kindly allow me to read the 3rd question. The 3rd question is from Dr. Mark Nganga. is commending for the great presentation. So he asking kindly highlight on the low diagnostic thresholds and accuracy of FDT vis-a-vis other modalities like Humphrey visual field, and whether we should use it or not. Thank you, Dr. Nanga. Okay, yes, back to you, Dr. Monicah Bitok.
So Dr. Oscar is asking the indications for SLT for laser trabeculoplasty. So in my experience, I've seen it works very well in primary, obviously primary open angle glaucoma. The angles have to be open. I also use it in juvenile open angle glaucoma, and it does very well in these young guys. I don't know why, but somehow the patients who've had SLT, the young guys, they are on no medications and their pressures are almost around 10. Also patients with ocular hypertension, normotensive glaucoma, steroid-induced glaucoma, exfoliation, and pigment dispersion. Though in those cases you have to use very low powers, it's useful. So basically, open angle cases, it's definitely a useful method of bringing the pressures down. I hope that answers. So Dr. Kibata is asking who should get TRAB and who do you with drops? For me, in a rural setup, most of those patients will not sustain the use of medication. So if you see a patient who has high pressures, and usually when we go out on those safaris, anyone who comes with glaucoma, we just do surgery. I think that's why Dr. Bitok is talking about retraining of ophthalmologists, and we need to up our trabeculectomy numbers. So for the rural setup where medication may not be accessible or available or affordable, do surgery on those patients. In the urban setup, I found even in my own clinical practice, it's very different, because a patient would rather be on medication that costs 5,000 every month and they're happy, and then undergo surgery. So once you've reached your target pressures and this patient is on his eye drops, you don't need, and he doesn't want surgery and he's not progressing, you just maintain him on the treatment. But out there in the rural population, it's a bit different. I don't know, Dr. Bitok, would you want to comment?
Maybe from my experience while at OSU, is that most patients, and even we've seen most of the rural settings, they're not able to operate, they have to refer. And we know you talked about patients not being able to afford bus fare to go to a referral center. So if such a patient probably could have something that won't have to keep them going back to hospital every other time, and probably that would be surgery. It will minimize probably the hospital visit, and you'll have good control, because if they can't afford bus fare, then most likely they can't even afford medication. So probably for the rural setting, probably TRAB would be the best, but Dr. Monicah, you're the glaucoma specialist, you're the expert. And yeah, I think I agree with you on that.
Maybe if Prof. Kiage is in the meeting, he can comment, because for me in the urban setup, we have so many options of medication and laser. Before we talk about TRAB, we usually have exhausted all these others. I don't know if Prof is in the meeting.
Okay, Prof. Kiage, maybe as maybe is coming in, let me read other questions in the meantime. So Dr. Nyamoria said that Dr. Nyamoria has directed the question to Dr. Monicah. So this one, it's you to Dr. Monicah. Do you think teleglaucoma fundus pictures technique will be replaced by nerve OCT screening? Then there's Joseph Ngugi. Joseph, you'll get the slides. We'll also, this presentation is recorded for future prosperity and for anybody who wants to review it in future. Then another question from Dr. Mungia: what will be your recommendation for patients with both cataracts and glaucoma? cataracts or glaucoma surgery first or combined? Then the last question is VFS had not been answered. Kindly remind, thanks, this one I'm not getting it directly. Anyway, there's one comment here from Dr. Kipsang. I think he's worried that we will think the transfemoral tonometer is his. Dr. Kipsang, don't worry, we know, don't worry if it's yours. We have seen you with the governor of Turkana, so we don't, will not be shocked if it's yours. I want to comment one person here, Dr. Stephen Osiemo. Osiemo is a senior ophthalmic clinical officer in Nyamira. He's the one who I found in charge of the department and is almost retiring. So thank you, Osiemo. Osiemo is basically telling us that he's happy with the presentation and the feedback and the acknowledgement. I want to thank you, Osiemo, again for attending this CME. Osiemo has worked here in Nyamira for a long time. He's the one who established the department, and he's the one who has made it possible for Dr. Mako and the team to do this study. Thank you. So back to you, Dr. Mako. I hope you are remembering the questions.
Okay, Osiemo, it's good to see you in the group, and we worked together at that time, and they were very instrumental in making this study a success. So OCT versus teleglaucoma, in terms of screening, teleglaucoma is it's expensive, and I can't really tell what the future will hold, because when you talk about screening, we're using fundus photos. At least in diabetic retinopathy, you've been quite successful. And the good thing, once you screen for diabetic retinopathy, you're going to see the optic nerve. So I can't tell you that, I can't say that the OCT will replace the fundus photos. These are very, very expensive equipment, both of them, but we'll see what the future holds. In terms of cataract and glaucoma, yeah, this is a very interesting question, Dr. Mundia. But if a patient has a visually significant cataract as well as glaucoma, I always do a combined, either combined small incision cataract surgery plus trabeculectomy, or phaco-trabeculectomy if the facility or the institution has the phaco machine. However, if the cataract is not visually significant at all and the patient has very high pressures, then do the trabeculectomy. But you also have to warn the patient that in future, the cataracts can develop much faster after trabeculectomy surgery. On the other hand, if the patient has a visually significant cataract and the pressures are completely well controlled on medication, so somebody comes, their IOP is 10 and they're on timolol and they have a visually significant cataract, just do the cataract. You don't have to do a combined surgery. So it really depends on the patient. What was the other question? I think there's more question by maybe Dr. Gishui, but maybe Bitok or anyone else can.
Dr. Gishui is not a question, it's a comment that there was a study that was done which showed that the number of trabeculectomies being done by the residents by third year was very low compared to the cataract surgeries, and probably the reason why we are seeing very few trabeculectomies in the field. Yeah. So it's just a comment and additional information.
Thank you, thank you. So there's someone here on my neck, Dr. Nganga. So this one I want to direct you to Dr. Mako. So he's asking again that kindly highlight on the low diagnostic thresholds and accuracy of FDT vis-a-vis other modalities like HVF, and whether we should use it or not.
FDT is a very good screening method where you're going to be able to pick out glaucomatous changes, especially the early changes, because it picks up very, very early changes in glaucoma. However, like in our study, I'm not sure if it was how the test was being conducted or the understanding of the patient, but we had such high errors, we could not even use that information. In terms of the Humphrey visual field is the gold standard for visual field testing in glaucoma, basically. So between the normal FDT and Humphrey visual field, if you're following up a patient, if you're screening in a rural setting like we are, and you're able to eliminate the errors that as a result of doing the test, then you can get pretty good results. For screening, FDT is very fast. We also have the FDT matrix, which is a bit more higher level than the normal FDT. And this one is good also for screening and follow-up. So if you're able to get that into the FDT matrix into your clinics, it's pretty good because you're going to be able to pick up the glaucoma scotomas and follow them up. Humphrey visual field takes a bit longer, although you have the fast, you can have the fast thresholds, but an Humphrey visual field, by the time you've transported it to a screening center, if you're thinking of screening, it's a bit bulky and very expensive. But if you're in a glaucoma or a tertiary center, it's a good thing to have because you're going to be able to follow up patients quite accurately and quite well. There are other machines that have come up that are competing obviously with the Humphrey visual field, and this basically are also very good for diagnosing and following up patients in a tertiary center. But why we use the FDT is because it's fast and it's portable. But the high number of errors, we could not really use those results. So I hope that answers a bit of the questions. But the FDT, if you're based in a center, a tertiary center, and the Humphrey or the other visual field tests are too expensive, the FDT matrix is pretty good, and it's slightly more affordable and is quite useful in diagnosing and follow-up.
Okay. Thank you, Dr. Marco. So there's a big up to you, Dr. Marco and Bitok from Ogada, saying this is a great presentation. Ogada will share the presentation and the link to our mails once we are done with the presentation. The administrator will do that. So there is Dr. Bongo. Dr. Bongo, are you there? Can you unmute yourself? There's a hand. Dr. Bongo wants to ask a live question, if I can say that. Dr.
Yes,
Bongo?
I'm Alan, yeah. Thank you. Mzuri sana, asante.
Karibu.
Yeah, I have just some a question for everybody, and then some complementary response to what has been done. Maybe Dr. Marco and others that are here might remember during one of the World Day Glaucoma, when we have a CME, I asked a question I did a comment to all the ophthalmologists, and I say, I'm coming now to, this is related to the screening, and particularly to the result that of the study that Dr. Mark was presented here, where 50% of the patients that have glaucoma are underdiagnosed when they have been seen by ophthalmologists. I did a comment and I say the first people to sensitize for glaucoma screening are the ophthalmologists, or to fight blindness of glaucoma ophthalmologists, because we don't do what we know. So my question to everybody is that, are we going to continue doing the same thing? Because that time people were saying, no, they have to pay before I check a IOP. Are we still going to ask that question when we have such kind of result where 50% of the patients that we see are underdiagnosed for glaucoma? Now coming to the tonal pen, For the experience that we have for the all-day glaucoma screening that we were doing in Kikuyu, the patients that were diagnosed with glaucoma, when we took the pressure on Goldman tonometer, there were always a variation for 2 to 3 higher on the higher side. So I agree with Dr. Marco that with the tonopen is, even if a patient, in my opinion, when a patient is 19, 20, it's better to counter-check when it's possible on Goldman tonometer. That is what I wanted to add. Thank you. And thank you, Dr. Marco and Dr. Bitok for this good presentation.
Thank you, Dr. Bongo. So I don't know if Professor Kiage has participated in this study. Prof, are you available to a comment? Dr. Marco looked for you earlier. Prof? Okay. Dr. Marco, any person, Dr. Bitok, that will want to comment before you close to another session?
I think all I can say is, okay, I hear what Dr. Mbongo is saying. Yeah, let's just treat anyone who walks into our clinics above 35 as glaucoma suspects, take their vision, take a quick pressure, look at their disc. It takes a very short time, and you'll be surprised that you'll be able to pick up more glaucoma by just, even these patients who come for specs, presbyopia, myopia, whatever, just do a quick examination so that we pick these things up. We pick glaucoma early enough. Thank you.
Dr. Bitok, your closing comments?
Yeah, so for me, I'd like to thank everyone. Just like to comment that in line with what Dr. Marco and Dr. Mbongo have said, I think everyone has a role, right from the clinician to the county level, to the national level, even to our international NGOs. So everyone has a level to play in glaucoma. It's not just waiting for the other person to do it. I think we can all do what we can within our capacity. Thank you.
Thank you very much, Dr. Bitok, Dr. Marco. Before this CMA has been sponsored by Novartis, and our routine, we have to give Novartis a chance to present. So Brian, are you?
Yes, I'm here, Dr. Hope you can hear me.
Yes, I can hear you. I can see your slides.
Okay.
So, yeah, kindly go on. Yeah.
Okay, thank you, Dr. Frank and OSK leadership for the great opportunity. I won't dwell much. I think I'll just highlight one of our medications, majorly for management of glaucoma. My name is Bran Barani. I work with Novartis. So I'll highlight on Azaga briefly. And with Azaga, we say you are able to lower the IOP with less discomfort. So what is Azaga? Azaga is our brand of brinzolamide and timolol combination. And Azaga is indicated for adult patients, those with open angle glaucoma, for whom monotherapy is usually insufficiently in terms of control. So why should you choose Azaga? Azaga is able to give you that power to drive.
Just a moment, Brian. Let me.
Okay.
I'm really sorry for disturbing you. I've committed a great sin.
Okay.
Pole sana, Brian. Dr. Gishangi. Dr. Gishangi, sorry, and I really wanted to talk to you. I even side chatted you, so I thought you are Dr. Gishangi. Kindly come on board.
All right.
Pole sana,
I had raised my hand, and I noted that you did not notice. Now, I wanted to just echo what Dr. Bongo had said, and what one of the comments, I think, from somebody, that there are already some patients who are presenting themselves to us, and we are missing about half of them. So it tells us that we have to look into ourselves, into our systems, and improve and ensure that anyone who presents himself that could be having glaucoma is well captured and receive the appropriate quality treatment. Thank you.
Thank you, Dr. Gishangi. A reminder to you, Dr. Gishangi, the people of Nyamira have told me that you promise them something. Na Waswahili wanasema ahadi ni deni na dawa ya deni ni kulipa. So Dr. Gishangi, you remember your deni? Yes.
Yes, thank you.
Thank you. Brian.
Okay, Dr. I can hear you. Thank you.
Continue, Pole.
Okay, no problem. Okay, so with Azaga, you are able to get the proven efficacy. Azaga is also able to give you that 24-hour IOP lowering effect, also has less ocular discomfort and a well-established safety profile. In terms of efficacy, when you say efficacy, Azaga is able to give you that proven efficacy. In a study just comparing the effects of Azaga over a dozolamide timolol combination at all the IOP measuring points, that at 8 a.m., at 10 a.m., and also at 4 p.m., Azaga was able to demonstrate non-inferiority over the dozolamide timolol combination over the 6 months period. Hence, that proven efficacy bit. Then, in terms of IOP lowering, glaucoma is a 24-hour disease. You need a 24-hour IOP lowering medication to be able to manage that. Azaga is able to give you that consistent nocturnal efficacy. This is majorly from a study that was comparing Azaga to brimonidine timolol combination as an adjunct to travoprost. And it was clearly seen that Azaga was able to provide that statistical superiority in terms of quality over the 24-hour IOP when compared to the brimonidine timolol combination. So that is able to be sustained over the duration. In terms of also the comfort, Azaga suspension itself, it's associated with less ocular discomfort, 50% less ocular discomfort when you compare with the dozolamide timolol combination. So what does that mean for your patient? That means that your patients will be able to have that better adherence, better tolerability, and also better therapeutic compliance to most of the medication. In terms of also the safety profile, Azaga has no adverse, more adverse events that the ones that are commonly seen. Most of the safety profile, it's well established, and no non-ocular or ocular adverse events were clearly categorized in that space. So choose Azaga for your patients majorly because it's able to give you that 24-hour IOP lowering effect. It's really less discomfort and able to give you your patients better compliance, better adherence, and better tolerability. And also the nocturnal efficacy. We know the IOP mostly spikes at night. Azaga is able to give you that consistent nocturnal efficacy, and also it is proven in terms of IOP lowering. And just to summarize, we are inviting you for an upcoming Simbrinza launch that is happening in Serena next week on Thursday. It will be hybrid, but we really look forward to ensure that you are able to be there also in person. There's a link that's available, so you can also use the opportunity to also register. We've lined up some great speakers and also some great talks. So really looking forward to ensure that you'll be there so that we can have great interactions. Thank you. Back to you, Dr.
Thank you, Brian, so much. Thank you for accepting to to host this presentation or to sponsor this presentation. Thank you, Dr. Marco and Dr. Bitok, for accepting to present for that wonderful presentation. Today we don't have any other announcement, so I really want to thank you all of you for attending this meeting. Our next CME will be exactly in 2 weeks from now. So we'll communicate. Thank you. You can leave at your own pleasure and have a good evening. See you in 2 weeks' time. May God bless you all. Asante sana.
Thank you.